Thank you very much. I will talk about fine needle biopsy of the thyroid nodule. And let me tell you that I prefer to say fine needle biopsy, FNB, instead of FNA, because the thyroid is so vascularized that most of the time the fine needle biopsy is going to be non-aspiration, so I prefer to say FNB. The objectives of my talk will be when FNB is necessary, how to obtain an adequate sample. This will be the core of my talk, and a little bit about when to do core biopsy. As you know, thyroid nodules are very common, and thyroid cancer occurs in 5 to 15% of these nodules. But unfortunately, considerable overlap exists between benign and malignant US findings. Then, when to perform FNB? There are many guidelines. We began doing that one of the Society of Radiologists in Ultrasound that we have modified in our institution according to the American Thyroid Association criteria. It's important the role played by the multidisciplinary meetings, and also it's very important in the management, a useful cytological classification. We use that one of Bethesda cytological classification. Then, when FNB is probably unnecessary, because this is important to have in mind, it's not necessary with cysts with smooth internal margins. Well, if there is a cosmetic problem, we can aspirate. Cyst with solid component that changes in position with movement of the patient. Sometimes you have something that looks like a nodule inside the cyst, and you move the patient and then falls like the lithiasis in the gallbladder. Mixed nodule, predominantly cystic with a vascular small spongiform solid portion, probably is not indicated FNB. Pseudonodules associated to chronic thyroiditis is not indicated FNB. Multiple nodules diffusely distributed throughout the thyroid without plane of separation, not possible to measure, is probably not necessary to do FNB. These are examples of pseudonodules associated to chronic thyroiditis. Here you see the more frequent pattern with these multiple hypoechoic pseudonodules. In this case, it's not necessary to do FNB. The opposite pattern, called by Bonavita et al. Giraffe pattern, is not necessary to do FNB. When in this context of chronic thyroiditis, you find a bright nodule, hypovascular bright nodule, it's not necessary to do FNB. Spongiform pattern is associated to benignity, and we are considering not to do FNB, but as we began doing the criteria of the Society of Radiologists in Ultrasound, we are doing FNB when they are at least 20 millimeters in maximum diameter. And the problem is that I think that there are some different patterns of spongiform patterns. Some of them are very clear, but others are not so clear. On the other hand, there are suspicious for malignancy. I think that these are the most suspicious findings. Microcalcifications, infiltrative spiculated borders is an important finding in my experience, and because most of the time the nodules have got not well marginated borders, and it doesn't mean spiculated. When you find spiculated, it has a high specificity for malignancy. Another thing is a very hypoechoic nodules. Very hypoechoic nodules, this finding is linked to malignancy. Most of the nodules are hypoechoic, including benign nodules, but very hypoechoic is linked to malignancy. We are doing FNB nodules smaller than 10 millimeters in our institution if the nodule is very suspicious for cancer, or there are other factors as PET positive or personal or family antecedents of thyroid cancer or clinical history of neck irradiation. If there is homolateral adenopathy with cytology of thyroid malignancy or suspicious for cancer, we go to the thyroid nodule, we puncture the thyroid nodule, and also we puncture the adenopathy. Indeterminate nodules, unfortunately, are the most frequent nodules. Most of the nodules do not have benign or malignant characteristic. We consider FNB in these nodules when they are 15 millimeters in maximum diameter. It's very important before FNB to get an informed consent. During that process, it's important to explain to the patient the procedure and the possible complications. And in this moment, you relax to the patient, talking to him and explaining. Most of the time, the result of the FNB is going to be benign, and that will avoid unnecessary surgery. Anticoagulation, yes. We avoid patients in anticoagulation and consider the procedure like a minor surgical intervention, like a tooth extraction. Local anesthesia, well, we explain to the patient that most of the time we will do 3 passes and it's not necessary to put anesthesia. But if the patient feels or demands it, we put it. Before the procedure, scan the neck with Doppler to avoid vessels in the needle trajectory. Advise the patient not to swallow during the procedure because swallowing increases the possibility of the most frequent complication. This is the unique complication I have had in puncturing 2,000 nodules, 3 passes with an average of 3 passes in every nodule. This is the nodule, these are the muscles, and here is this hypoechoic semilunar image. This is the most frequent complication, subcapsular hematoma. We always say to the patient to stay outside the room. In this case, we ask the patient to stay at least 30 minutes compressing the point, and after that 30 minutes, I check with ultrasound how is it going. In my experience, always this has been auto-limited and even smaller. After FNB of every patient, we say to the patient to stay in the radiology department for 15 minutes doing local compression. If the patient feels something is not going well, we will check with ultrasound. If the patient feels good, he can leave the department. He or she has not to say anything to us. Yes, he feels good and he goes. Once the department has been left, the patient is advised to go to the emergency room if he or she knows swelling. There are key points to FNB success. First point is to go to do the adequate election of the nodule. It's very important to go to this suspicious nodule. Also, it's very important to do US-guided FNB, to set the needle in the solid peripheral vascularized portion of the nodule. You have to know during the procedure when you have got enough sample in your needle. It's going to make an average, in my experience, an average of 3 passes. And it's very important to know how to smear the sample, because if you don't know to smear the sample, or if you even doing all the previous steps right, you don't get enough, you don't get sufficient cytological material for cytological analysis. I have done in my institution a comparison between US-guided and not guided FNB in almost 400 nodules doing by the radiology department by me, and another group of the same number of different nodules performed by pathologists. without US-guided FNA. We have seen that the procedures, when they are done by the radiologists, multiply by 4 the probability of nodule to go to surgery. So it's very important to put the needle in the more suspicious nodule in the correct part of that nodule, solid, vascularized, peripheral portion, avoiding cystic spaces. Never do a mark point in the skin to let another doctor to perform FNB. Different elements are necessary to perform FNB. The probe, high-frequency probe, we recommend to protect with a cover. Well, most of the time, the needle is not going to touch the probe, but it's more hygienic, and you protect the surface of the transducer. Also, I put a mark in the transducer just to know where exactly is the middle, the center of the transducer, because most of the time I do the perpendicular method to control the needle. Most of the time I use the blue needle, the gauge, 23 gauge. If the lesion, the needle is deep, then I will use the green one, the 21. And also the syringe. The syringe most of the time will be just for holding the needle, because most of the time the puncture is going to be non-aspiration, because the thyroid is so vascularized, and if you begin with aspiration, then you have more probability to get bloody material. Most of the time, I do 3 passes, and then I got 3 samples, and I got 6 smears to send to cytological analysis. This is the learning curve in my experience. This is my insufficient cytological material in my first 1,600 cases. Every 100 cases, you can see the average of sufficient cytological material. Right now, we are around in 5%, but look at here. We began with almost 40% of insufficient cytological material. How do I do this learning curve? Well, you have to know how to select, how to choose the suspicious nodule. You have to learn to put the tip of the needle in the right part of the nodule. You have to know to smear the sample. And here you see this curve going down. And this is what was due, like later I will show you, due that I was smashing. I wanted to do it so well that I was smashing the cells. This is an example of insufficient cytological material, bloody, no apt. And for cytological analysis, the pathologist will need at least 6 groups of cells with at least 9 cells in each group into different specimens. Before the first pass, I put the syringe in this position. Just when I take out the needle, I don't have to, when I do the procedure, I don't have to take out the needle before putting the specimen in this last glass. Aspiration or non-aspiration. The thyroid is so vascularized that it's best to begin with non-aspiration technique. And in the same procedure, if you don't stain the needle, make aspiration. US-guided parallel or perpendicular. At the beginning, I began controlling the needle in parallel when the nodule was very small, and doing perpendicular when the nodule was large. But as I have learned, I feel more comfortable doing perpendicular method in every nodule because the skin is closer to the nodule. This is an example, an image, how you see the needle in the parallel, US control in parallel. This another case. It's an example of a mixed nodule with a cystic portion. In this kind of nodules, I don't aspirate at the beginning, as some authors said. I just go to the solid portion of the nodule. You will see Okay. It takes its time. Oh. Mm-hmm. I don't know what to do. It was working.
You may just need to close it down and then go back to this slide, if that's okay. Yeah.
Well, I have another slides that the same, but I'm very interested in showing them.
So we're going to have to restart the program. So, let's just try this once. It had started.
It doesn't know as well. Not functioning.
No.
Well, this particular is not so important to show it, but I think it's very important that works in another video that I have put in it.
Yeah. Again, it's
yesterday it was working pretty well. I don't know. Thank you.
No, I don't think it's going to work, Francisco, I'm afraid.
Is this key?
Yep. So I think we'll need to move on to the next slide.
Okay.
And hope the next one works.
Okay, I will do that. Yes, thank you very much.
Come on. There we go.
Okay, in this video, you will see how I do the procedure. The needle gets inside and out, to and fro, and then I rotate in a clockwise and anti-clockwise direction. Like you can see the movements, quick movements. And here in this video, this is a tiny noodle. This is just the tip of the noodle. And you will see well, what this video supposedly had to show how the tip of the needles getting inside of the plane of the noodle, getting inside and out. So you are completely sure you are completely sure that the tip of the needle is inside the needle, because when you get out the needle, then you lose the image of the tip of the needle. Once the tip of the needle is inside the noodle, then you see the bevel, the tip of the noodle. In this process, if I don't stain, the aim of the procedure right now is to stain the needle. If you don't stain the needle, I used to say to my assistant radiologist, just to keep his or her eyes in this portion of the needle, just to be sure it stains. It stains. Okay. So, by the way, during the procedure, if I don't stain the needle, I put the cover in this way just to do the same movements to and fro and rotating the needle in a clockwise and anti-clockwise direction. Another option is to say somebody just to help you. And while you are maintaining the tip inside of the needle, say someone beside you to aspirate. And don't forget to say that you have to release the aspiration before taking out the needle. Once you have stained the needle, you put in a row in the slot glass in this way. And now, if there are a lot of specimens that this is very rare, then I can get 2 slide glasses smeared by one of these. So for one of these correspond 2 slat glasses. And then in that case, I don't need to do the 3 passes. This is an important step. Just to know how to smear the specimen, you have to do it in a softly way, not to smash the cells. This is an important step. Once you have your smear in the last glasses, you can set it for cytological analysis. And now it's very important, the Bethesda cytological classification. T is from thyroid, T1 insufficient material, T2 benign, T3 follicular proliferation of uncertain origin, T4 follicular neoplasm, T5 suspicious for malignancy, and T6 malignant. The cytological classification determines the management. T1 and T3 repeat FNB in 3 months. T2 nodules, we continue following up for in 10 months because there is some papers saying that there is a 5% of false negative cytological results. And if T2 with suspicious use findings, we will repeat fine needle biopsy. We always repeat fine needle biopsy in 3 months to avoid the atypia phenomenon. And T4 and T5 and T6 will go to surgery. In T2 benign nodules, we use to control in approximately 10 months. Fine needle biopsy, if there is substantial growth, we have seen that benign nodules growth, and we consider to puncture again when they grow. The growth is more than 50% of the volume with at least 2 millimeters in 2 of the diameters, according to the ATA 2009. Then, when to perform core needle biopsy? Core needle biopsy of the thyroid nodule demonstrates high rates of conclusive and accurate diagnosis in patients for whom previous FNB results were non-diagnostic, thereby reducing the need for unnecessary diagnostic surgery. But if insufficient cytological material is low, core needle biopsy is exceptionally needed. But if there is suspicion for lymphoma, do core needle biopsy. After the second insufficient FNB, I would propose, if there are sinister US findings, just to do core needle biopsy, because the alternative is surgery. If the nodule is indeterminate, we could do core needle biopsy or probably a third FNB. If the nodule is spongiform, follow-up, and probably if it is really spongiform, just nothing. And always multidisciplinary meeting play its role. There are limitations inherent to core needle biopsy because of the complication rate increases, the size of the nodule to be biopsied increases in expertise hands with a minimum diameter of 15 to 20 millimeters. So conclusions, FNB is indicated according to the nodule US findings, guideline, and multidisciplinary team discussion. Begin with non-aspiration, and if the needle does not stain, change to aspiration until the needle stains. Remember, the aim is to stain the needle. Properly smear the sample in the slide glasses. Cytological classification, Bethesda cytological classification determines the management of the nodule. After a second non-diagnostic FNB, core needle biopsy, it would depend on the nodule size, US findings, and clinical history, and always multidisciplinary team discussion. Okay, that's all. Thank you.